Hi everyone, and thank you for inviting us to come today. I'm Claire Skinner. I'm the Director of the Hornsby Emergency Department, and I'm a specialist emergency physician and medical educator by background. And I feel like a complete fraud because I've been in the job for about a year and a half, so I inherited this fabulous service. The engine room of the service is Nadia Yazdani, who's the clinical nurse consultant who runs the Grace service. And she's a bit of a all-rounder. She has a background in aged care, mental health, palliative care, nursing, and also some training in accounting and commerce, which I think makes her almost the perfect person to run this service. And if it's okay with you guys, we're going to share the talk. So a little bit about Hornsby first. Hornsby Ku-ring-gai is an outer metropolitan district hospital. We're level 4 and we're located in northern Sydney, so our local big hospital is Royal North Shore. At the moment we're seeing about 45,000 presentations a year to emergency, which equates to about 110 on a normal day and about 140, 150 on a big day. And roughly 20% of our patients are aged over 70 years. In the ED catchment area we have 52 residential aged care facilities, which equates to about 8,000 beds or 8,000 potential patients. And according to the last census, we come fourth in the whole of Australia for the longest life expectancy, and which we're only eclipsed really by the coastal belt of Queensland. So we have a big vested interest in getting this right. So just to talk a little bit about the Grace service. Grace stands for Geriatric Rapid Acute Care Evaluation Service. And Grace is no news. In fact, we won this equivalent award in about 2009, and I feel we're still going strong. Grace was implemented as a pilot in August 2005, and it was originally funded by New South Wales Health Funding, which was aimed at reducing ED access blocks. So it came through the Sustainable Access Program originally. And I think it's been kept going because it has hit its targets and it's demonstrated that it improves patient flow, and it's had such a significant impact on our patients and our community. The idea for Grace came from a Division of General Practice survey which identified some need for doing aged care better in the community. So we'd identified that patients were often ending up in emergency, had long stays, often became low priority on a triage category 3 or 4 compared to some of the more acute presentations, and were a little bit of a heart-sink patient for the team in emergency because they're not really our area of specialty. So I think we all identified then that we needed to do this better. The Grace model was developed collaboratively, and I think that's one of the reasons why it's lasted so well. So it was a project of the aged care service, the emergency service, the residential acute care facility managers, and also the local division of general practice. So everyone owns it, and I think that's one of its strengths. Now, the thing to say about Grace is that in its simplest model, it could be thought of as hospital avoidance, but I actually think we do far more than that. So Grace is really about making sure we provide people with the services they need in the best environment for them. And it's very guided by research that demonstrates that elderly patients who end up in the acute care hospital system often are not done any favours by it. They're at increased risk of delirium, increased risk of falls, increased risk of pressure injuries, and they actually have long stays. So the idea of Grace is not just keeping people out of hospital, but actually trying to provide them with appropriate care. So how does Grace work? Grace, as I see it, has 4 major roles, and these have come and gone a little bit over the years, and each of these roles is needed differently at different times. So that the main function of Grace is to be a single point of access for liaison between the nursing home community and the emergency department. So if someone in a nursing home or a GP with a patient in a nursing home feels that emergency care might be needed, they know who to ring and who to get some advice about that rather than just putting someone in an ambulance. Grace works this way as a sort of telephone triage service, an information sharing service where we can actually get patients' details sent in advance, get some warning about the patient and get a little bit set up for their needs. And Grace can also do things like refer people to outpatient clinics, refer them to APAC, which is our hospital in the home service in northern Sydney, organise outpatient radiology and community appointments. So that single point of access, I think, is Grace's major role, led by Nadia. The second thing we realised is that not everyone was well served by staying out of hospital. So the second aspect of Grace is it serves as a fast-track model for those patients that do end up in the emergency department. So the Grace team can perform an early focus assessment in ED. They can allow things like someone coming into ED and literally getting fast-tracked to radiology and then sent back with an early result, or perform the procedure that's needed. So for people needing a catheter change or a nasogastric tube change now get fast-tracked through the ED rather than waiting category 5 in the queue to be seen. The third feature of GRACE, and this one's growing and growing, is that GRACE does capacity building in the residential aged care facility sector. So we run regular education and support forums. Nadia goes in and does in-services with the nursing staff in aged care facilities around things like procedures, wound care, medication safety, etc. And we do a lot of networking between our local GPs, our aged care sector, the emergency department staff, and the residential aged care facilities. And I think probably the most important aspect of GRACE is now the GRACE service exists, GRACE has an important advocacy role to a hospital and area health service exec. So now that GRACE exists, we have a very visible presence around aged care within the hospital system, and that's been very useful as well. Now, an interesting thing to note is that while our GRACE service is based in our emergency department, our priority is actually the whole system. So this is not just an emergency department program, and I think absolutely one of the strengths of this is actually emergency department outreach, demonstrating that the emergency department actually benefits by thinking beyond the immediate emergency medicine setting. So who is GRACE? Nadia is our clinical nurse consultant, and she works Monday to Friday. We have a number of registered nurses in our department with both ED and aged care experience, and they cover the after hours component of it. And we've combined our GRACE service now with our aged care services and emergency teams, our asset service. So we have an expanded ability to help out residential aged care facilities around the clock. Also, we've recently added a medical component to the GRACE service with a geriatric emergency medicine registrar, which we've managed to get funding and support through the ACM Special Skills Program. So that's been really good too, and adds to the role. So, does GRACE work? Well, we won the prize before, and interestingly, the next presentation from Newcastle, they actually came sussing us out. So it seems that we work. November 2005, 536 bed days per month were occupied at Hornsby Hospital by nursing home patients. By 2006, 1 year into the program, 300 bed days per month. By 2008, 45 bed days per month, and we're currently sitting at 38 bed days per month for nursing home patients in Hornsby Hospital, the oldest demographic in metropolitan Sydney. We've got evidence that 95% of patients who present to the emergency department who are aged over 75 years get through the emergency department in less than 4 hours. And I have to admit, that's good going for us. We have a large paediatric burden, we have a large mental health patient presentation list, and so our aged care patients now actually win the NEAT. And the other nice thing is we have excellent patient satisfaction ratings. So people aren't feeling like they've been kicked out, they're actually feeling like they've been supported and redirected to a more appropriate form of care. So there's evidence we're doing things right. I thought it might be useful for Nadia, our CNC, to actually tell you a patient story to illustrate a little bit how GRACE works. So over to you, Nadia.
Thank you. Hello, everybody. There are so many stories to tell, but one that actually stays in my head for the rest of my life is looking after a 76-year-old Helmet from a residential aged care facility with chronic ulcers. He had a past history of CVA, NIDM, AF, chronic renal failure, and depression, and he was they put an indwelling catheter for him because of he was incontinent. He wouldn't allow any family member to see him because the ulcers were so smelly. So the geriatrician actually was overseas in France. He rang me in the morning and said the daughter rang him to tell him that he's not allowing his family to see him. Can we go and see him? Last year in July, the GEM registrar and myself, we went to visit him. He wouldn't allow anybody to see him, but he allowed us to see him. His family, his daughter and wife were staying outside his door crying. We went inside, the GEM registrar, geriatric emergency medicine. He went and talked to the GP, and I talked to the family and the registered nurses. We started working straight away on IV antibiotics because previously the oral antibiotics wasn't working, and we gave them instruction on how to look after the ulcer. After a few days, he was getting much better. His ulcers were improved. After 21 days, he was actually able to walk. Last week, I went to see another patient in the same facility. He actually asked to see me. The photo that you saw just before, that's Helmet. He's 77 now. He started to walk, and his condition much improved, and he's actually visiting his wife on his electric wheelchair.
Okay, so Grace works there too. So a little bit about where we're up to now. Grace is a work in progress. It's growing and developing. We've recently been working strongly on ambulance liaison, so we now have a system where we can actually look at the ambulance booking system online, identify when an ambulance is called to a nursing home, and we can actually intervene at that point to offer the nursing home staff assistance and advice. We're implementing a telehealth project where we can video conference between ED and nursing homes to try and allow remote access and assessment of patients, so we're running a virtual Grace clinic. We have the geriatric emergency medicine program growing. And then we actually have continuous ongoing collaboration and liaison with community-based practitioners trying to finesse the service. So that's where we're up to. I think something I'd just quickly like to say is part of the reason why this happens is because Hornsby Hospital Executive Team and Northern Sydney Local Health District have offered us so much support, and we work in a very positive and collaborative culture. And I think I literally work in the best emergency department in the world with the best creative, hard-working clinical team. And our local community really supports us as well, and all of that is important. So thank you very much.
Thank you. I'll get you back up later. Thanks very much indeed. And we'll talk to you later during the questions. Keep your Slido questions coming in. And there are other parts of New South Wales Health that are doing this. One is South East Sydney Local Health District. Jerry Marr is here, hopefully with a microphone. Jerry, so this is... Are you getting similar benefits?
Yes.
I'll provide simultaneous translation for Jerry.
He's from the posh part of Glasgow, so he can't understand me either. We are getting similar benefits, not only in terms of the flow into our hospitals, but also, importantly, the quality of the care that our elderly patients population actually get. We've seen some really dramatic reductions in the percentage of nursing home patients coming into our ED departments. I think Peter Glinski's here this afternoon. He's been the driver behind the Sutherland Flying Squad. It's really well established now and producing very good results.
So this is about contagion, Jerry. Mm-hmm. How successful have you been at contagion in South East Sydney Local Health District? Because my understanding is pretty good around Sutherland, not bad around St George. It's been a real job to convince Prince of Wales to come and play.
Yes, I mean that's a
So how much evidence do you
comment.
need to convince clinicians to actually come and play here?
Well, what we're actually doing is that we've actually purchased an analytical tool that we are using, and I'm actually beginning to...
called a hammer, is it?
Yeah, it could be. That's the second tool we'll use.
Right.
We'll use the analytical one first. But I actually do believe that when you begin to show clinicians the data, they really begin to engage in the conversation. They resent the idea that you're coming to them with a contagious idea from another district when they don't see the evidence. So now we're sitting down with them and saying, this evidence is absolutely compelling, and there is no reason why we wouldn't spread this across the whole of the district. So that's the stage that we're at.
Thanks, Jerry. Also, Kay Hyman's here for the Chief Executive of Nepean and Blue Mountains, LHD. What's been your experience, Kay?
Quite similar to what we've heard. We have a slightly different service. Ours is called the Virtual Aged Care Service, so it has the elements of emergency department avoidance and smoothing the pathway where people do need to come into hospital, but also has a third arm which is around early follow-up and mobile phone access to geriatricians for general practitioners, residential aged care facilities, and in fact our own community health team. So the results have been very similar to what you've heard.
So reduced avoidable admissions?
Yes.
Fantastic, thanks very much indeed. You already had a sort of sneak preview that Hunter New England is going to present here, and Jacqueline Hewitt, who's an aged care emergency clinical nurse consultant in the patient flow unit, is going to present on the Newcastle and Hunter Valley experience. Jacqueline.
You know now you give me something that nobody else has got. And this love that I've been wanting, oh baby, it's turning out to be
Hello, everybody. The aged care emergency service concept in Hunter, New England commenced in 2009 when it was noted that there were increasing numbers of residents from aged care facilities with low acuity clinical problems presenting to our emergency departments. ACE is now a partnership between Hunter, New England Local Health District, Hunter Primary Care, and is dependent on collaborative relationships with Hunter New England Central Coast Primary Health Network, residential aged care facilities, New South Wales Ambulance, general practitioners, residents, families and carers. I want to begin with the story of Mr. B. He is an 82-year-old gentleman with chronic obstructive pulmonary disorder. And in the last year of his life, Mr. B had 38 ED presentations, 18 hospital admissions totalling 61 days, 160 blood tests, 25 x-rays, 2 ultrasounds, a gastroscopy and a colonoscopy. Mr. B died in one of our emergency departments, not a ward and certainly not at home. Whilst figures vary, depending on which survey that you read, about 70% of us would prefer to die at home if they were comfortable and well supported. Despite this, around 54% of Australians die in hospitals. The emergency department, as you all know, is a risky place for older people. There is an increase in morbidity and mortality associated with the older people being in emergency departments. They're at risk of all of these issues listed on this slide, but as you'll note from the previous slide, they are also at risk of numerous, potentially unnecessary invasive procedures. The best outcome for residents with multiple comorbidities with overlying low acuity problems is to be treated at home in the residential aged care facility by staff that know the resident and know their normal condition. Potentially avoidable ED presentations obviously include management of chronic conditions, imminent end-of-life issues, infections, wound management, coughs, urinary symptoms, etc. can often be safely managed within the aged care facility. The use of the ACE service with the ISBAR for Aged Care clinical handover tool, along with clear communication of potential goals of care, of patient goals of care, has been critical in managing the patient journey. The ACE service model is a model of care that is multifaceted and it comprises 7 key elements. These elements were designed from the direct feedback of key stakeholders at focus groups, and at the centre of the model is the resident, and all of the elements are critical in ensuring that they receive the right care at the right time and in the right place. It's a 24/7 telephone support model for aged care facility staff, and the phones are manned by ED nursing staff during the day, and the patient streaming service with Hunter Primary Care in the after hours, weekends and public holidays. The ACE nurse coordinates the sharing of clinical information between aged care facilities, GPs and the ED, and the aged care facility staff are responsible for organising the ambulance if necessary and all of the supporting documents. These are just some examples of the resources that we've made available for aged care facility staff, and they include an evidence-based clinical manual, a website, newsletters, facilitated quarterly interagency meetings, brochures, posters, training workshops, and telephone support provided by registered nurses. Hunter New England Local Health District obviously sits north of Sydney and covers a geographical region of an area approximately the size of England. For this reason, we needed to develop an enablement model for support for aged care residents and not a rescue model. We were unable to send a specialised team in to support staff in situ due to the vast geographical area, and hence we had to enhance staff skills and their accountabilities, build trust and relationships, and integrate existing hospital avoidance models and strategies from other organisations as well as our own. This format has also allowed for whole of health initiatives to be communicated to our partners via our existing infrastructure and assist in reducing the perceived discharge barriers that can often occur with communication breakdown. In 2013, the ACE service grew enormously when it became multi-organisational model and not a model between hospitals and aged care facilities surrounding them. We now have shared governance between the local health district, the primary health network, Hunter Primary Care and New South Wales Ambulance, and a service level agreement between all parties exists. A lot of work was also done to accurately identify aged care facility residents in our patient management system software, both within Hunter New England and Hunter Primary Care. We link standardised address with the unique RAC ID and can run reports accordingly. And it's not until you actually have to manually sift through the 25 different ways that an address can be written in the system that you realise how hard it is to know if someone that is in your ward, in your hospital or at one of your clinics resides in an aged care facility. Collaborative partnerships between Hunter Primary Care, Hunter New England Local Health District Aged Care Facilities, New South Wales Ambulance and GPs also allow the RACFs to be supported 24 hours a day, 7 days a week, across 8 of the 9 hospitals involved. We have a steering committee that oversees governance and determines future directions, shared data and accountabilities, and we have regular stakeholder interagency meetings. There's also an operations subcommittee that delivers on service plans, education needs, and reporting to various stakeholders. In 2012, a 2-year pilot involving the ED at John Hunter and only 4 aged care facilities concluded. We now have approximately 80% of aged care facilities in our area implementing the ACE service. This equates to approximately 130 aged care facilities, or over 6,500 aged care facility beds. The 9 emergency departments that are participating range from tertiary referral hospitals, district hospitals and also local community hospitals, so the model is very adaptable. ACE is an established and successfully integrated service and has received multiple awards: the Medicare Local Innovator of the Year Award, 2 Hunter New England Quality Awards, an innovation grant to introduce telehealth, and probably most proudly a National Better Practice Award from the Aged Care Quality Agency, where Bupa Cardiff submitted an application for Embrace the ACE. In 2014, an evaluation conducted by Hunter Medical Research Institute and Considine Consulting found that the majority of opportunity cost savings occurred in New South Wales ambulances and the associated EDs, with annualised cost savings of $920,000. And they also found that there were 981 ED visits avoided, and an average of 74% hospital avoidance when phone calls to ACE occurred. This followed on from a pilot study in 2012 where John Hunter conducted a case versus control comparison. And as you can see, there was a large variation in the number of transfers per 100 beds. But what we also found was that with our case aged care facilities, there was a 45% reduction in hospital admissions, a 45-minute reduction in ED length of stay, and a 35% reduction in hospital length of stay compared to the RACF controls. These are just some examples of the positive responses that were voiced in the evaluations in focus group interviews. And the key message today is that shared governance and accountability has been the absolute game changer with this model. We've reduced potentially avoidable presentations to ED with reduced associated risks, ED congestion, demand on the ambulance service, reduced economic burden on health services, but we've improved access to resources for those in most urgent need. We've improved the quality of clinical handover with better informed decision making, especially around the individualised goals of care for the residents coming from aged care facilities. and this has ensured that the aged care facility residents receive the most appropriate care in the right setting. It's very patient-centred. Telehealth is obviously the next frontier, and we've currently got a pending transitional research grant submission. There have been a number of publications that are available and about the ACE service, and thank you if you want to know more.
Thanks, Jacqueline. Fantastic. Really good news. Thank you very much indeed. We'll get you up later for the questions. And final presentation, this subsegment of this afternoon's presentation on this area is from Anne Mellor, who's Chief Investigator and Clinical Nurse Consultant in Advanced Care Planning in South East Sydney Local Health District, a major issue which we touched on earlier with Health Direct. Anne.
Thanks for inviting me to speak today. My apologies for Professor Gideon Kaplan, who couldn't be here today, so he would have liked to have been. It's kind of weird talking about projects before they actually start, but I've been asked to just talk about a project that we'll be doing across our LHD, South East Sydney LHD, in partnership with Sydney LHD. Earlier this year, we were successful in applying for translational research grant scheme funds to translate what we know about advanced care planning into the hospital outpatient setting. Our initial expression of interest wasn't probably quite as ambitious. However, when it was suggested we approach outpatients and the services in our LHD, we thought, well, what have we got to lose? Hopefully, not a lot of friendships and things. So what is advanced care planning? So most of you here will know what advanced care planning is. So I can see some nodding going on there. And if you don't know what it is, then just quickly read the slide and keep nodding your heads and pretend that you do know what advanced care planning is. Like all things, process is important. We know we can increase the knowledge base to clinicians. That's the easy bit. It's the same stuff for everybody. For many health professionals, it's about applying that new knowledge to their clinical cohort of patients. So what's the evidence base for advanced care planning? There's plenty of evidence to support us doing advanced care planning, both internationally and locally. The evidence is from a variety of settings that we don't have time to expand on today. Lots of people have been chipping away at this for decades now. We know it's person-centred. We know it promotes autonomy. It promotes shared and supported decision-making. We know it's multidisciplinary. It even helps with brownie points for accreditation. It's part of integrated, chronic, coordinated, specialist, primary, supportive, you name it, care. It's a bullet point everywhere. It ticks all the right buzzword boxes. We know. We're all really smart. We know it's really good. So why don't we do it? We're so smart, we put up professional arguments and barriers. Why me? Oh, not this again. Again? We haven't even got started yet. We say, but. Patients change their minds. Advanced care directives aren't legally binding. Well, that's an oldie, but a very much out-of-date goodie. What about those demanding families? So we're great at putting up barriers. And why me? Captain Picard there. Or we think it's a really, really good idea. It's so good, in fact, someone else should do it. Really? Come on, we've got the GPs are doing it. Yep, they're on board. Residential care facilities have been doing that for quite a while. The families, well, sort of, as a last resort if the patient hasn't or is unable to. And that's funny because all those other players say, oh, this is something that should be done in hospital. So talk about cat and mouse. We're never going to get anything done here. Hospital specialists, geriatricians, yep, they've been at it for decades. Did I see Peter Kennedy here before? Because he probably started the ball rolling back in the mid-1990s. Palliative care specialists, they've been doing that in more recent years, and that's generally their core business. We've got renal care and respiratory coordinated care programs who are implementing advanced care planning. And for goodness sake, the intensivists are even on board on the bandwagon. So, you know, for goodness sake, we can all get on with this. So there are other specialties out there. It's really just thinking ahead for your patient, who they might want to speak for them if they couldn't speak for themselves. And then the next but is, I'm busy. I couldn't possibly. I don't have that kind of time. Research demonstrates that hospital wards are not the ideal setting for advanced care planning because decisions made when acutely unwell in an unfamiliar setting could markedly differ from decisions made when people are in a stable condition in their usual environment. Raising the topic in ED hasn't worked. Ideally, it's done at home around the kitchen table by starting a conversation. There's no such thing as a free lunch, and be very wary if your mother invites you for lunch on Sunday saying, there's something I want to talk to you about. For our study, we suggested outpatient clinics, chaotic as they might be in some areas, might be worth trialling as an in-between place to have these discussions. They're linked into the acute care system, and there's communication between acute and primary care, but away from the emergency department or inpatient setting. However, there is a lack of training and support for outpatient clinical staff to, one, identify patients who might benefit from those advanced care planning discussions, and two, to actually facilitate that conversation. So we hope to phase in that comfort level with interested clinicians who feel this might benefit their patients. So you might be saying, well, who's doing this? So we only started in July, so we're just putting the word out. So South East Sydney LHD, Sydney LHD, New South Wales Health, the University of New South Wales, Ambulance Service, Alzheimer's Australia, University of Sydney, and our local primary health network. Perhaps some of the South East Sydney LHD employees or attendees here today may not even be aware as yet. It's so hot off the press. So feel free to contact me if you do work in the LHD and might want to know a little bit more. So what would all those people know, all those partners? You might be thinking, well, because we've been doing our own bit, chipping away since 2001 to progress the cause. We've worked with community groups, we've worked with residential care, divisions of general practice to Medicare Local to PHN over the years. Now it's time to push the envelope a little further and see what we can achieve. It's good to partner with like-minded people to broaden the scope and to take a few others along for the ride. So what we're actually doing in this project, we'll be conducting a randomised control trial to determine if facilitated advanced care planning intervention with outpatient department clinical staff can provide positive outcomes and improve patient care. We aim to recruit 364 patients with advanced diseases identified at risk of dying within the next 12 months. These patients will be attending hospital OPD, such as, but not limited to, cardiac, respiratory, aged care, dementia, liver and renal services, located at Prince of Wales, Sutherland, St George War Memorial and Calvary, and at Concord Hospital in Sydney LHD. The intervention participants will receive the support of an experienced facilitator to help them to think about and make decisions on their preferred decision maker, their goals of care, their future treatment decisions, and collaboration with their usual treating healthcare team or teams. We tend to have lots of teams. The facilitator will also help communicate the person's wishes to their local doctor, specialists, treating health professionals and the wider health system to ensure they'll be followed in the future. As the clinician becomes more comfortable with starting this conversation, the facilitator withdraws. Thus, the knowledge is translated. In terms of evaluation, the primary measures will be unplanned admissions, but we also want to look at the flow-on effect of what substitute services are used instead. It's those secondary measures that actually shape future service planning. We'll also be conducting focus groups of patients, carers and clinicians to ascertain their perspectives on the whole process. We're just doing the ethics application and recruiting staff, so it's a very exciting time ahead. If you're interested in learning more, feel free to contact me. But I think it's time now that I've got to be careful how I say this, that we shut the butt up and get on with it, myself included. I think I've run out of time. They're my contact details, so thank you for your time.
And if you just take a seat, and if the other speakers could come up while we're talking, and we bring up the Slido questions. By the way, Slido is an exercise in democracy, so if you click the like button for questions that you like, when you look at it down on the screen, that puts the question up on the list. The question I have here is, I don't know where the others have gone. The question is, how do you avoid disenfranchising general practitioners when you put in these programs, particularly a successful outreach program?
Sorry. So you've really got to do the sell for what's in it for them, regardless of what program, outreach, inreach, whatever program there is that the GPs are involved with. I think that's the key: good communication and keeping them involved right from the get-go. Claire?
I mean, it's a critical issue because the GPs might think you're just taking it all away from them and doing your own thing.
So I guess the difference with our project has been is that the Division of General Practice has been involved from the start, and there are a number of key opinion leaders in our local general practitioners who are very involved with our programs still, and we have regular forums. And I make it very clear that they are the patient home. So we've been very keen to make it clear that we're not taking over. You own the patient, you know the patient best, we're here to support you.
What about the cultural needs of the clients in the ACE program, Jacqueline?
Sorry, I missed
the
that.
Cultural needs of diverse needs, and
Being having an area health service that covers both metro and rural, we've got very diverse needs. The rural sector is quite different to some of the metropolitan areas with the multicultural group that we have. Rural people are generally more pragmatic, I feel. So, you know, that whole idea about approaching death in the country feels, because I've worked in both the country and metropolitan areas, it feels a much easier conversation in the country than it does in the metropolitan areas. I don't know why.
So Claire, why wouldn't we just make these outreach programs mandatory? Why are we sort of faffing around here?
The challenge with it is that it crosses a federal-state funding divide, and it crosses some well-known silos. So I think there's very different governance structures between general practice, between the aged care facility sector and between the acute hospital sector, and that's been a challenge.
So there's no avoiding negotiation in a fairly deliberate process?
It's really difficult. So you have to negotiate across those boundaries, and you have to really prove that things work to get any of those sectors to take a strong interest.
And what about rapid response to people living at home rather than residential aged care?
Sorry, can't hear you.
What about rapid response that goes to people at home as opposed to residential aged care?
I think that's something we're all interested in doing, and definitely our aged care services and emergency team has much more of a focus towards people at home, but they're harder to identify. So for us, we've kicked off the one where we have the structure to actually get involved because there is a governance structure around the aged care residential sector. So we picked that off first, but it would be lovely to expand this to people at home. It's just harder to communicate with them, and I think that will be a role for growing relationships with the Division of General Practice.
Please join me in thanking our panellists for this session.